Hello, I am a psychiatric pharmacist and an assistant professor working at major university in Japan. Today, I would like to talk about antipsychotic polypharmacy. First, I will give some background on antipsychotic polypharmacy. Then, I will present the results of survey of antipsychotic polypharmacy in outpatients with schizophrenia at Naga University Hospital. Finally, I would like to discuss about considerations for antipsychotic polypharmacy. In the next few slides, I will show you an overview of antipsychotic polypharmacy. Polypharmacy is the use of two or more medications to treat the same condition, and antipsychotic polypharmacy is concurrent use of two or more antipsychotics. As shown in the figure, antipsychotic polypharmacy is common in psychiatry, with approximately 30% of patients with schizophrenia receiving antipsychotic polypharmacy. The prevalence of antipsychotic polypharmacy is 10 to 50%, and recently it has been reported around 20%. It has been shown that the use of antipsychotic polypharmacy in schizophrenia often results in excessive daily dosing, and antipsychotic polypharmacy can cause adverse drug events at an early stage with high frequency compared with monotherapy. This is a scheme of vicious cycle of antipsychotic polypharmacy. Antipsychotic polypharmacy is associated with excessive dose of antipsychotics and can cause adverse drug events. It eventually leads to poor adherence and poor clinical outcomes, and increases healthcare costs due to utilization of healthcare services. Therefore, it is one of the important roles of psychiatric pharmacists to identify and assess the current status of antipsychotic polypharmacy and provide strategies for improvement. Now, I would like to talk about the results of survey on antipsychotic prescribing trends from 1997 to 2007 at Naga University Hospital. In this survey, we aimed to investigate polypharmacy and excessive dose of antipsychotics in outpatients with schizophrenia and to suggest strategies to promote optimal use of antipsychotics. Outpatients with schizophrenia who received oral antipsychotics from 1997 to 2007 were included in this study. Patient characteristics, prescription profiles of all drugs, and their doses were obtained from patients' medical records. We classified psychotropic medications into 5 categories: antipsychotics, antiparkinsonian agents, anxiolytics, sedative hypnotics, antidepressants, mood stabilizers. We then calculated their frequency of use and the equivalent doses, and this study was approved by Ethics Committee of Naga University. At first, the prescriptions of outpatients with psychiatric disorders for 5 days in each year were extracted from the electronic medical records. Of the 15 outpatients, 827 schizophrenic patients were included in this survey. This slide shows the proportion of the number of antipsychotics. Blue boxes are monotherapy, and red boxes are polypharmacy, 2 or more antipsychotic users. The frequency of antipsychotic polypharmacy was around 36.3% and gradually decreased. Most of the patients were treated with monotherapy, suggesting the optimization of antipsychotic medication was progressed. In Japan, second-generation antipsychotics have been commercially available since 1996. After commercialization of second-generation antipsychotics in Japan, the rate of monotherapy and also polypharmacy using second-generation antipsychotics has increased. As shown in the figure of prescription rate for psychotropics, the first-generation antipsychotics have decreased, second-generation antipsychotics have increased, and anti-Parkinsonian agents have decreased correspondingly. The frequency of extrapyramidal symptoms may have decreased due to an increase in the utilization of second-generation antipsychotics. The equivalent dose of antipsychotics was classified into low to optimal dose, high dose, excessive dose, and the prescription rate for each were summarized. The equivalent doses of antipsychotics was found to be low throughout, and more than 80% of patients were within the optimal dose range. Equivalent doses of antipsychotics are shown in the figure. The antipsychotics were around 300 mg chlorpromazine equivalent, which was relatively low dose but was controlled within the optimal range in most patients. Imipramine equivalent doses of antidepressants increased from 1997 to 2003, which may be related to commercialization of SSRIs and SNRI in Japan. Biperidaine equivalent doses of anti-Parkinsonian agents decreased due to the decrease in antipsychotic polypharmacy and increase in the use of second-generation antipsychotics. We next investigated whether antipsychotic polypharmacy lead to excessive dosing. As a result, significantly higher chlorpromazine equivalent dose of antipsychotics was observed in polypharmacy compared to monotherapy, either first or second generation drugs. The correlation matrix between the number of psychotropics and their equivalent doses is shown in this slide. Correlation coefficients are shown as numbers in the table and highlighted in red and blue according to magnitude. Red numbers indicate statistically significant difference. The strongest correlation was found between first and second generation antipsychotics. The data showed that users of second-generation antipsychotics were less likely to use first-generation antipsychotics. The second strongest correlation was positive correlation between first-generation antipsychotics and anti-Parkinsonian agents. On the other hand, for second-generation antipsychotics, there were no association with anti-Parkinsonian agents. First-generation antipsychotic users were more likely to use concomitant anti-Parkinsonian agents, but not in second-generation antipsychotic users. The risk of developing extrapyramidal symptoms may be higher with conventional first-generation antipsychotics, or inappropriately concomitant preventive use of anti-Parkinsonian agents. The growing use of second-generation antipsychotics is thought to be leading to safer pharmacotherapy. This is a summary of the survey results. The proportion of antipsychotic polypharmacy and the number of antipsychotics has decreased over years, but similar or slightly higher than in other countries. In addition, the equivalent dose and prescription rate of anti-Parkinsonian agents has decreased. These results suggest that the increased use of second-generation antipsychotics and improvement in polypharmacy have led to more optimal use of antipsychotics and less requirement for anti-Parkinsonian agents to treat adverse drug events. However, since these results are based on data from 15 years ago, more recent studies are needed. There is still a certain proportion of patients who have antipsychotic polypharmacy. Therefore, it is important to figure out the reasons for it. This is the final part of my presentation, consideration for antipsychotic polypharmacy. So, why does antipsychotic polypharmacy occur? Several common reasons for the use of antipsychotic polypharmacy include incomplete cross-titration, enhancing efficacy, and amelioration of side effects. However, the evidence for efficacy and safety of antipsychotic polypharmacy is insufficient, and treatment guidelines do not strongly recommend it. The position of antipsychotic polypharmacy in various treatment guidelines for schizophrenia is summarized in this table. Commonly, antipsychotic polypharmacy is considered after failure of monotherapy with 2 or more second-generation antipsychotics and subsequent clozapine monotherapy. There are several studies of antipsychotic polypharmacy. It has been suggested that clozapine monotherapy is superior to any monotherapy or non-clozapine antipsychotic polypharmacy. RCTs have reported that clozapine combination therapy is superior to clozapine monotherapy in improving psychiatric symptoms and reducing metabolic side effects, but is associated with more other adverse drug events. Adjunctive aripiprazole could have been considered for improving negative symptoms and addressing symptomatic hyperprolactinemia or other metabolic effects caused by other antipsychotics from 2 RCT reports. Recently, it has been reported that antipsychotic polypharmacy reduces the risk of rehospitalization compared to monotherapy, especially the combination of clozapine and aripiprazole. Taken together, although review of the diagnosis and establishment of proper adherence is required before attempting antipsychotic polypharmacy, certain antipsychotic combinations such as clozapine plus aripiprazole or other antipsychotics may be useful. Also, the current treatment guidelines may need to be updated. I would like to thank all the people who have been involved in this work. Thank you very much for your attention.